Welcome to the After Hours Clinic with Dr. David Janarious and Better Life co-founder Andrew Lane, where we unpack the science of health and wellness, cut through the noise, and add a healthy dose of humor.
Dr. Dave, we're back.
Good to be back.
Welcome back to the Better Life After Hours podcast. This is what it's like to have a best friend as a doctor. So I just want to share this with the world and hopefully get out some useful information that, that our patients, that our friends, that our colleagues, and maybe that a few, strangers out there listening to this podcast can benefit from. So, today we've got another medicine in the media edition here. I saw this article. When I sent it to you, is that the kind of title that jumps out at you at all?
I don't think the title was salacious enough for me to really get interested, just because I read through so many salacious titles. But yeah. I'm so glad you sent this article, because it is a banger of an article that I have a ton of opinions on. I know you have a ton of opinions on. And I think it overlaps so well with what we try to do for our patients. So I think this is an important article to touch on.
So I'm scrolling the news feed an embarrassing amount of time. I'm really embarrassed to say this is every day, but it's true. It's like every day I'm scrolling the news feed. My wife and kids are constantly telling me to stop, and I thank them for that. Like, I really want to be off my phone more. I really want to be engaged in the life. I want to be living life around me, not addicted to my screen. Mm-hmm. And I know we've read several books about that, but this is the kind of thing that rewards me for looking at my screen, because it's like, this is the kind of stuff that, I don't know, it just really appeals to me. The title here, it's from the Atlantic. And for those listeners who maybe people are starting to catch on, whatever kind of person reads the Atlantic a lot, I'm that person. Like, I'm a sucker for at least 50% of the articles they put out. I'm like, preach. Like, if I could make a church and we just read the Atlantic and maybe the New Yorker, I think that would be my church.
I feel like my mental schema of the Atlantic is it's kind of a higher brow level of journalism. Is that accurate? Is that how it's perceived?
I mean, certainly I like to think so. That's how I think of myself, is that I'm reading sophisticated news, And I suspect the people of the Atlantic would be quite happy to have it described that way. I mean, it's a little more analysis. They are giving you ideas of what to think. They're not just giving you the news. Like, it's not just the facts. It's quite a bit of commentary. So I'll admit that there's plenty of bias in it. But by bias, I'd like to think it's well-reasoned analysis, and I don't always agree with all of it. But it's not a great place to get the what happened today in the world from, right? It's not your up to the minute news source. It's not CNN or Fox News.
It's not your news feed or 24-hour news cycle.
No, it's not. But if something's in the news, they're probably writing about it within a week or so. So it's kind of I think of the Atlantic as how to make sense of the world we're living in. And it's a lot of current events. And anyways, this article popped up and I could tell right away it was related to medicine, because even on my Apple News feed, it had some image that was it has the word hospital in the title. It had some image that was a stretcher. And here on the screen, it says, a barbaric problem in American hospitals is only getting bigger. Patients are getting stuck in the emergency department for days while waiting for a spot at an inpatient ward. And this is preaching to the choir in a way that I love it. For the preaching to the choir analogy, I think it's meant to mean like you're boring the choir, right? I don't know. Most choirs don't want to be preached to. Isn't that the case?
Well, yeah. Well, I thought people went to church to be preached. Oh no, actually, the choir's not supposed to. I don't even know.
Dude, people go to church to be seen in their big hats and their fancy clothes and to get free childcare. Come on, people go to church to get free childcare.
Yeah, I guess the idea is the choir is already in agreement, so it's kind of an echo chamber. So there may be a little bit of a bounce off echo chamber between you and I, but I think
Amen.
For readers, I think this is important for them to hear.
Yeah. So right away, I'm like, people are getting stuck in the emergency room. This is my biggest fear. This is what we try to help patients avoid all the time. And do me a favor, summarize what you read here.
Yeah, so this article was written by a former ER physician who is now retired, who details her own struggles getting care, accessing it through the ER for her husband who had end-stage esophageal cancer. And for those who don't know, end-stage esophageal cancer tends to be an aggressive form of cancer. By the time it starts spreading, the survival is abysmal. Basically, her husband was in the last phases of life. And during this time, they had gone to the ER many times with just a number of issues. And to the point where her husband was like, please do not take me to the ER.
I will not go to the emergency room became my husband's mantra.
Absolutely, because I'm sure that man suffered just immensely by these trips to ER. So she tried her best to kind of rig her own setup at home to keep him out of the ER. But ultimately, in the final analysis, did have to take her husband to the ER where he passed. And she talks about how, she experienced with these immense ER waiting periods. So, not only, waiting to be seen by an ER physician, but after being seen by an ER physician, generally what an ER physician, their job is to stabilize someone who's acutely ill and determine whether once they've been stabilized, they're safe to be treated at home or if they go into a hospital bed. Given the severity of his condition, almost certainly he met the criteria to be in a true hospital bed. So not just in the ER, but actually admitted to the hospital where you're on a hospital floor getting care. However, the ER and the hospital were so overwhelmed with patients that ultimately her husband would wait for days, even up to a week in the ER, which has very minimal staff. It is like next to no privacy. If anyone's ever been in the ER, it's just an awful experience.
Dude, my daughter broke her heel bone as a 3-year-old. And we were in the ER and we went to what I thought was a better ER. And we still ended up with like a schizophrenic right next to us, like just separated by a sheet, a schizophrenic, like losing his mind for hours, just to find out that like all they were going to do was splint it. And because it wasn't a children's hospital, they didn't have like pediatric splints. They just like jerry-rigged what they could. Like they could have had us in and out of there in 30 minutes. They could have just been like, you're going to need to see a pediatric orthopedist tomorrow. This has become my life mantra, which is why this article just like jumped out at me, like stay out of the ER.
Yeah. In that case, that's a perfect example of something that I could handle generally over the phone and walk you through.
Oh, yeah.
In her case, he had much greater problems that likely did require admission. But the thing is, here's the crazy part is once he would get to the ER, they would evaluate him and say, yes, he does need to be admitted to the hospital. And once you're admitted to the hospital in an actual bed, what that means is, one, you're in a much more comfortable room, a private room most of the time. You have much more staff per patient. So if a patient has...
the staffing ratios are enforced.
In the actual hospital bed, it's just a much better level of care. But the thing is, here's the crazy part. The ER doctor would admit, quote unquote, admit her husband to the hospital. However, he would remain in an ER bed during the entirety of the admission for the most part.
For days until they had room in the regulated part of the hospital or the regular part of the hospital. Yeah,
exactly. And the thing is, the crazy part is, while you are not getting true hospital level care, you're getting ER care, the insurance company is collecting as though you're in a hospital bed.
The hospital is collecting, the insurance company is paying.
Sorry, I apologize.
Yeah. Basically, you're getting charged at full rate. You're getting charged emergency rates for this half rate service that you're getting. They described being stuck like in hallways, in shared rooms with two or three other roommates. Staffing ratios where like you're not even getting clean sheets, and the nurse is pointing you towards changing your own sheets. It's just insane. I mean, it's really sad that that's such a large portion of people's time at the end of their life can be stuck in circumstances like this.
Yeah. So, as we're saying, I wouldn't say they were getting charged the emergency rate. They were being charged the hospital admission rate and getting emergency care kind of level.
Oh, I see. I see. Either way, they're getting, the billings are hefty, right? I mean, we're talking thousands of dollars a day.
Yes, but the billing is higher on the, on the hospital side versus the ER side.
Got it. So they're being charged full rate for inpatient care, but they're not getting inpatient service. They're getting ER overflow, I think is the term that you were using. ER overflow service.
Exactly. And she was talking about why this phenomenon seems to be present in major metropolitan areas across the US. And a lot of it is sort of perverse financial incentives. So she actually mentioned something that I thought was very interesting. She said, when I worked as an ER doctor, we would do something called diversion. And diversion is where basically an ER says, hey, we are at capacity. It's not safe to bring any more ambulances here. People can still walk into the ER, but if there's an emergency, like a 911 call or a transport from another clinic, they're not supposed to take them to that ER. They're supposed to take them to a less full ER. And in fact, that was something that we did very frequently when I worked in California with Kaiser Permanente, is have the ERs go diversion for safety.
When you practiced in the good old days of the 20 teens.
Exactly. Yeah.
Yeah. When you were practicing in Kaiser in the 20 teens. Yeah.
And what she was pointing to is, especially with COVID, what ended up happening was nursing salaries increased, admin salaries increased, and all of a sudden there was this push to take as many patients as possible. Not only are they not diverting ER traffic coming in, meaning your ERs are overwhelmed, but also she mentioned something important. In a diversion scenario, what happens is you eliminate beds, or you eliminate patients that are using the beds for elective procedures. So, for example, let's say someone needs a cardiac cath. That's the thing where they actually go in through one of the veins in the arm or the leg. They thread a catheter to look at the heart and see if there's blockages. A lot of those can be done on a non-emergent basis. So what they would do is they would schedule patients in the hospital beds for these kind of procedures. And what she's saying is, in the case where the ER is overwhelmed, they should not be booking these. They should be rescheduling these.
So that makes sense if you're optimizing the hospital and health, the medical system for greatest utility. But it doesn't make sense in today's world where you're optimizing the hospital for greatest financialization and greatest profit.
Exactly. So what she was pointing at is these elective admissions actually generally yield more dollars. So let's say, for example, to give an example, like let's say you went in because you had pneumonia and you needed a hospital bed, but that bed was being used by someone who's getting an elective like hip replacement or, an elective cardiac cath. The payout they would get by keeping you in the hospital bed for a couple of days, just giving you IV antibiotics, pales in comparison to the payout they would get by doing that elective procedure. So there's inverse financial incentives that are keeping hospital beds filled, and also perverse incentives to accept as many people into the ER as possible. And so what combines to give you this setting where people are just waiting, hours upon hours to even see an ER doctor. And once they've seen them, if they have to go to the hospital, they'll wait there in this awful ER setting, receiving their quote unquote, inpatient care. But that inpatient care is definitely not the inpatient care in the ER pales in comparison to what you get in an actual hospital bed. And to be quite honest, can be unsafe. And so I think she did a good job of pointing that out.
I mean, this is really partly a story about the private equity takeover and the financialization of the entire medical system, right? We see this with like every industry, and it really bites us in the ass during times like COVID and anytime there's stress to these systems, where if everything's run as lean as possible, if everything is had all the fat trimmed out of it, everything's optimized to the tilt, then there's no excess capacity because it's all been sold off. And I mean, the article talks about how with high salaries and high labor costs, which is what we want for this country. We want to be a first world country where people are making a good living. But with that comes this idea that we can't let the hospital continue to run with excess capacity, and it's just a waste of money to have empty beds.
Yeah. And so, a little background, like my first gig out of residency was with Kaiser Permanente, and I worked in what was called an urgent care. But in reality, it was truly just a fast track ER, meaning, this wasn't a place where coughs and colds went. I mean, we got coughs and colds, but we were actually getting a lot of, I'm coming with chest pain and shortness of breath. I'm coming in with severe abdominal pain or the worst headache of my life, things that would generally go to an ER. And our, urgent care was set up such that we could run stat labs. We could get CT and MRI imaging. We could push IV meds. In fact, I've even cardioverted people, meaning I've taken people with, an uncontrolled, unstable heart rhythm and use chemicals to put them back into a regular rhythm, which is something you never really see in what's considered.
You have to cuddle them and sing them a lullaby too, right?
Well,
I'm pretty sure I've seen special coding on the insurance forms for that.
Well, that's where the patient satisfaction scores came in.
Right.
Actually, I was very proud to say that I had very high patient satisfaction scores during that time.
Sure, yeah.
I actually, my average patient satisfaction score was higher than the average satisfaction score for primary care doctors, which those are people with established relationships with their patients. So I felt like I struck a good balance, not to pat myself on the back too much. But what this experience really taught me was that so much of what goes through the ER in the hospital can be managed outside of the ER in the hospital. And I really became an expert at keeping people out of the hospital, keeping people out of the ER. And that has, really complemented our practice so well. Because we've never really run a report we should, but like our patient panel has next to no ER utilization because we handle so many things that would traditionally be sent to the ER, either via a telephone call, a video visit, or, in some cases, an office visit, but most of the time actually remote with real good success.
I think that's one of the most valuable things we're offering our clients. I think people imagine that some people imagine that they want to be able to get into the ER quick. Some people imagine they want television, movie star treatment where, like whatever the CEO of the hospital is getting or the board members of the hospital are getting. But in real life, like there might be some secret door for the CEO, but in general, like I just see high net worth individuals getting sucked into the same flow as everyone else. Like this is maybe a testament to the fairness of the system, but the system is fair in a way that just gives everyone the same shitty experience. It's terrible. Like I don't want to get in and out of, I don't want to get into the ER faster. I want to avoid the ER altogether because the ER is where if you have kids, they need to like spend 2/3 of the time evaluating whether you've abused your kids, which has nothing to do with, it's sometimes nothing to do with the medical reason you're there. The ER is where they need to say like, oh, you're not dying fast enough, so we need to make you wait behind this crazy homeless person that just got in line. Or the cops just brought someone in, so we need to deal with that. The ER is just like the worst place in the world to be. And then you spend hours and hours waiting to find out that like, oh, you're going to still need to see a specialist, so just make that follow-up appointment.
So I think you touched on some good points. One, yeah, I mean, it's not completely fair. If you're in the Epstein class, you will get in faster or see one of his many private doctors.
Right. Yeah. I mean, if you can get the Jeffrey Epstein treatment in the ER, sure, take it if you can get it. But
Well, I was going to say, even if you can get that special treatment, like for example, like if the hospital CEO comes in, they're not going to wait, right? But if you can get that special treatment to see it, even if you could see, I could promise you're going to see a ER doctor within 5 minutes of, you showing up. Let me tell you, the ER is the absolute worst place to get care. This is a real problem. And one of the things that, she doesn't touch upon in the article that I think is really important to note is there are high levels of uninsured and underinsured people that access their ER like it's primary care. So if you don't have insurance and
Yep.
your blood pressure is 180 over 120 or something, what do people do? They're like, oh my God, the sky's falling in. Let's go to the ER. And so the ER doc will generally give you a couple doses of medication. And when your blood pressures come down, maybe they'll send you home with a single prescription for a single blood pressure medication and tell you to see your primary doc. But they're not experts at managing long-term blood pressure. They're experts at making sure you don't die. We see so many people that are uninsured or underinsured that have chronic issues that they've seen a bunch of doctors and they don't know what to do. So they think, let's go to the ER because they have the answers in the hospital. Trust me, unless you're dying, the answer or very sick, the ER or the hospital generally does not have the answers.
I just have to admit, like, I used to be really dumb about this. I used to, and I know people who've been really dumb about this. Like, it's harder than ever to get an appointment with a primary care doctor. It's harder than ever to get an appointment with a specialist. And there are busy people, even with insurance, who see the ER as like, oh, okay, I'll just brute force my way into the solution I'll just go to the ER on Sunday and have it taken care of. And it is the absolute like worst thing you can do, because if you're not dying, you're not going to get the care you want. They're just going to, at the end of the appointment, they're going to say like, and here's what we can do to keep you alive, and go see a specialist.
Let me give a tale from the ER to make this like real for patients or not for patients, for listeners. Right. So you will remember this case. This was, I think, like in 2023, 2024. We had basically, it wasn't even our patient at the time. It was a family member of a patient who I guess had high blood pressure for a very long time, but just, wanted to do it the natural way. And one day woke up feeling, a little headachy, a little nauseous, and his blood pressure was through the roof. We're talking like 200 over something, and he went to the ER. The ER gave him a couple doses of a blood pressure medication, saw his blood pressure come down a little, and sent him home with a prescription for a single blood pressure medication and said, see your doctor within a week. The family member called us because they were concerned that maybe this wasn't the best care. And that person, spoke to me, and I said, okay, tell me about your ER stay. And they're telling me, and I said, well, what was the result of your CT scan? They're like, they didn't do a CT scan. And I was like, you need to go right back and get that CT scan. And so we did. And we actually called the ER and said, hey, do not let this man go home without a scan. And we're lucky because he had a massive brain bleed. So like, even in a situation where there is an emergency, because the ER is so overwhelmed, even that can oftentimes get overlooked. And don't even get me started on the fact that most of the time these days when people go into the ER, they're not even seeing a doctor. They're seeing a nurse practitioner or a PA, which is, I'm not here to...
Hold on, let me put a quarter in you. How do you feel about this mid-levels taking over medical care?
Yeah, I mean,
that's more about the financial engineering and financial optimization of the system, right?
Yeah. I mean, they may be able to wear the same coat. They may be able to get their doctorate degree.
Do they get to wear the same coat? They get to wear the same uniform?
Yeah, we don't. It's not like a dress.
That is a bridge too far. That is a bridge too far. You went to medical school. You're a full-fledged physician. You deserve your own special coat. Come on.
I never wore the white coat because I'm like, I'm not a fucking scientist. Like, why do I need a? I always just wore scrubs and like.
Did you wear the stethoscope around your neck at least every day?
Yeah, that's the prop, so they know I'm a doctor.
And one of those badges that was like full of like all the different laminated things. Yeah.
But you know, you're not even necessarily getting the best emergency care there. We could give so many countless examples of patients that have called in saying, you know, my kid has a fever of 104. You know, I'm thinking of going to the ER, and we're like, no, calm down. Did you try ibuprofen and Tylenol? Did you do a flu test? And it's something as simple as, oh, they just had the flu. Here's some Tamiflu. Just rotate ibuprofen and, you know, Tylenol. But so many patients, even if they have an established PCP, they can't get that answer quick enough. They're going to freak out. They're going to go to the emergency room because it's their kid. Just yesterday, we had a patient who lost vision in their right eye. And that is something that if you tell your doctor in a standard practice, they're just going to say, go straight to the emergency room. But this is a patient who I worked with, who I knew quite well, who I understood that this is unlikely to be a life-threatening medical emergency. And we were able to keep them out of the hospital and get the requisite testing they need as an outpatient.
Yep.
It is, I'm trying to think of the last patient. It's hard for me to even think. I can't remember.
Who legitimately needed the ER. Yeah.
Yeah. I can't remember the last time I told a patient you need to go to the ER.
So I had a pediatrician. This is a few years before we started working together. I had a pediatrician just do me such a solid. Did me such a solid. My daughter had fallen off of a changing table. She was quite young, and I was in full panic mode. I yelled for my wife. We put the kids in the car, drove to the emergency room immediately. You know, I thought this is a head injury. But thankfully we had the presence of mind to call the nursing line at our pediatrician's office, and he did me such a solid. Unfortunately he's passed away. I can't thank him enough. Like, I should track down his family. And because what he did is he got on the phone with me immediately while I was driving to the hospital. And he said, I'm actually finishing up my rounds at this exact same hospital. Instead of going to the ER, meet me in the parking lot. And he came out to the parking lot and he did an exam on my daughter. And he said, you're fine. She's fine. Everything will be fine. Monitor these vitals. Go home. Don't get stuck in the ER for 8 hours on a Sunday morning. Like,
the doctor.
It's the doctor. Yeah. I mean, it's just my children's pediatrician. Like, I wish I forget about this story too much. Like, I need to track down this man's family. He died young, unfortunately, of pancreatic cancer, sadly. But I need to track down this man's family and do something for them, because he just the what he did for me was just so much. You know, I mean, in an era of cover your ass medicine, he did the opposite. He did hand-holding, you know, he did real hand-holding, white glove medicine. He came out to the parking lot, met us, told me right where to meet him. He walks out in his scrubs. He's getting off of an overnight shift. And he's like, listen, man, I'll tell you if you need to go into the ER or not. And he did a 5-minute exam and realized, like, my daughter was fine. Like, she did not need, and he could have been wrong. She could have gotten worse. He could have lost his license. He could have lost everything, but he just did the right thing. And unfortunately, I think today, like, we're so used to cover your ass medicine that people are like, oh, I don't know. I don't want to be responsible. Go to the ER, that I think some people get the wrong message about how useful the ER can be. Like, it sends the message that the ER is the important place to go. And in reality, like, the vast majority of problems don't require the ER.
Yeah, I mean, you bring up a really good point with this, you know, cover your ass or CYA medicine. I'll bring it back to that story I was telling you about, that patient who lost their vision.
Hold on. This is not medical advice. This does not establish a doctor-patient relationship. Consult your doctor before blah, blah, blah. Well, we got to cover our ass, but yes.
I'm not saying don't go to the ER. So this is a patient I had a very established relationship. And, my wife, Mrs. Dr. Janarious, who works solely in the hospital, she, I actually called her, because she would have been the one on call to see her. And I said,
Yeah.
hey, I know this patient. I know her full history. I know her risk, but I am 99% certain this is actually just a migraine. I don't
Yeah.
think it's necessarily like a stroke, because that's what you're worried about when someone loses complete vision in one eye. Do they have a blood clot form in the artery that goes to the eye? And, Mrs. Dr. Janarious, she knew clinically you are most likely correct. But she's like, I've seen, because, migraines of this type are a risk factor for stroke in and of themselves. So she's like, I've seen people with that history who've had this a bunch of times and still coming with a stroke. So, I'm going to say, from my perspective, of someone who, solely sees patients in emergency situations, that I think for, if anything, just for legal reasons, you should, admit this patient in the hospital. And she said, I can even sweeten the deal and get her admitted directly to the hospital. And I spoke to the patient and offered her that. And I said, this was the concern of, the specialist. She agrees that this is most likely a migraine, but this is what she's seen in rare cases. So the odds are in your favor if we do this as an outpatient, but the risk is not completely zero. And knowing this, like, how would you like to proceed? And, this patient said, no, I'd like to just do, avoid the ER, avoid the hospital, do this as an outpatient.
Schedule the follow-up tests. Yeah.
Yeah. And I said, oh, that's exactly what I would do. But I don't, as the viewers may not know, but as anyone who knows me knows, I do have a fairly high risk tolerance in general, just in my own life. Ride my bike without a helmet, ride motorcycles, that kind of thing. Not my motorcycle without a helmet, just my bicycle.
No, just your bicycle. Which, by the way, I've been telling you about the movie E.T., Extraterrestrials, the 1991 movie that everyone else in the world has seen but you. I want to point out that the little boys in that movie ride their bikes without helmets. So there was a time called the 80s, the 90s, and every time in between, every time before, when the whole world rode their bike without a helmet. So it's only in the safety culture of the 2000s and beyond that everyone needs a helmet. I'm very pro helmet. I understand some people need to live their life.
Yeah, I mean, I'm not anti-helmet. It's like putting on sunscreen for me. I didn't grow up doing it, so I never think.
Yeah. So, I mean, it sounds like you were with proper counseling, discussion of the risks, informed consent, you were able to save this patient. They would have ruined their day to go to the ER and sit around, because they would have been a kind of a non-urgent case because they're not actively dying. She would have sat around for hours and hours and hours, and she might have even gotten admitted for observation, but because maybe the test, the CT scan or whatever the appropriate test was not available. So this could have easily turned into a multi-day admission for her just to find out that she didn't have a stroke.
This was her birthday too, so.
Oh man, this would have ruined her birthday surprise with her family.
Yeah. So, there was all kinds of reasons to avoid the hospital. And I'm really, some of my proudest moments are when I've helped people avoid the ER. Another story that I think really pertains really well to this and will kind of bleed into something that I wanted to touch upon that I think was absent in this discussion. One of my favorite success stories, if you want to call it, when I used to work in that, urgent care, fast track ER setting. I remember I had a patient who was 101 years old come in with, the nursing home brought him because he had some chest discomfort. And, lo and behold, his EKG had some abnormalities. I ran a stat troponin, which looks for heart injury, which is a sign that you're having a heart attack. And it was elevated. It wasn't extremely elevated, but it was elevated enough that he was definitely having a mini heart attack. I looked at this gentleman and I said, yeah, you're having a mini heart attack. Here's the thing. We could absolutely send you to the hospital and they will likely offer you a cath, maybe a stent. If it's bad enough, it could even mean open heart surgery. Let me ask you, you're 101 years old. Is this something that you want to do? And he's like, no, absolutely not. I've lived a really good life. I'm happy to go out. I want to go out comfortably. And so what I did was, instead of calling the ER or the hospital, I called the hospice company, and I actually got hospice set up in his nursing home that day. He came home, they were already getting all the things he needed set up for hospice care. And, I checked in a couple months later, he's still alive, because as Atul Gawande detailed in his book, Being Mortal, people who choose to go on hospice actually live longer than those who seek aggressive care. And that topic of hospice was missing in this. What I was wondering the whole time was, why was her husband with this advanced stage esophageal cancer not on home hospice? Like, there are so many things that could have been done, I could have prevented him from coming in and allowed him to die peacefully. He ultimately died in the hospital bed.
Yeah, no, that is missing from the story. Why wasn't he on hospice? Yeah. That is a good question.
Being an ER doctor and not necessarily thinking about these things.
It sounds like she was running her own hospice at home, to be honest with you.
She wasn't, though.
She talked about how she had basically set her house up to be an ER. In order to avoid the ER, she'd set her own home up as a makeshift ER.
Yeah, she says she jury rigged it, but I hear, because what do you really want? Because let's talk about this guy's specific case. So at the end of the article, she talks about how he was having shortness of breath. They took him in. He was waiting forever in the ER. And then she said something that drove me crazy. She said, well, I told myself I would never do this, but
I went straight to that part of this. Yeah. I promised myself I would never do this.
And I'm like, bitch, what do you mean? Why didn't you call? Why didn't you
call it a favor? You worked your ass up. You worked for decades in that hospital. Yeah.
If I was her husband, I'd be like, because basically what she said is, I finally called a contact who got him whisked into a hospital bed. And if I were her husband, I would be so mad. Like, hold on, this whole time I was suffering in ER and you could have just made a phone call. This is like that scene in Dumb and Dumber where he's like, hold on, you had an extra pair of gloves this whole time? Like...
To be fair, I mean, she sounds like a Boy Scout who's trying to always wait her place in line and never cut the line. Like, I want to agree with you that, like, if I'm her husband, I will have wished that she made that VIP call earlier. And at the same time, like, society could use more people like her who are willing to wait her turn and not have to use connections to cut the line. But yeah, I mean, where's the dignity in death here? I mean, it's she got her dignity, but she got her husband his dignity, but she had to call in a special connection to do it.
It didn't sound like it was really that dignified of a death. It ultimately, I see a much more dignified death being one at which he was at home.
In hospice, at home.
They realized that, hey, this guy is short of breath. He probably has fluid in his lungs from the cancer. Let's start pushing morphine and Ativan on a continuous drip to keep him comfortable as he passes away. Whereas this guy for hours or days or whatever it was in the ER until she was like, let me stop self-flagellating and call for help.
Yeah. I mean, this is a very unsatisfactory end to the article. I want to put a bow on this article, at least, despite how much commentary we may continue. Like, the end of this article is her husband passes away in the hospital after she makes a phone call, pulls a connection, and gets jumped to the front of the line for a proper hospital bed where he's got a real bathroom in his room and he's got real nurse care and he's really being taken care of. And then he abruptly dies within a few days, it seems, in his hospital bed.
Dies calling out her name for help.
Right, which is, to your point, and unfortunately, they don't discuss it in this article, but I think it's going to be something we're going to have to record an episode on just for my benefit. Like, my grandfather is almost 91 and he's going through this repeated hospital merry-go-round of getting admitted 2 or 3 times a year and suffering through a lot of these same indignities of being in the ER for a while, getting transferred to an inpatient bed, having something happen there where he's got to get transferred to another hospital. He's just going around department to department. Sometimes his hospital stays are 3 days, but usually they're 3 weeks, and sometimes they're 3 months. And he might die I don't want to be insensitive about this. I love my grandfather, but he might die gasping, calling out my mother's name. He might die calling out someone else's name in confusion. He might die at home in his sleep. And I can tell you which one of those he'd rather do. He'd rather be at home in his sleep, comfortable, than suffering the indignities of hospitalization. But unfortunately, I think there's a real lack of literacy in this department in terms of like, what is hospice? When is it for? When is the right time to do it? And I think the mainstream news story on this is like, you don't want death panels deciding when you die. You should always be entitled to the best, most scientifically advanced life-saving procedures at all times. But I think that really sells us short and distracts us from what a better way to, a better plan for the end of your life.
It comes down to the fact that most people just have not seen death up close and what it looks like, right? And they haven't seen death in a hospital as many times as a doctor or a nurse. And, they don't understand like just how uncomfortable that experience is. She talks about in the last admission when they brought him to the ER, how he was sitting not in a bed, but actually on the hard, like kind of like stretcher that they bring him in from like the
board. Yeah. The stretcher board. Yeah.
Can you imagine what that must have felt like? Like dying, gasping for air, probably nauseous as hell, feeling like you got to throw up all the time.
On a cutting board, on a hard plastic board. Yeah.
Yeah, basically on a cutting board. And I think, your grandfather, who I think is worthy of a little background. I mean, he's not just your average granddad. He's a total badass.
My grandfather served his country active duty military for over 30 years, 32 years of active duty military service, was on SEAL Team 1. He was in the Vietnam War. He was in the Korean War. And then, and he had a storied career as a SEAL, and he did high altitude parachute testing for NASA. He went to, he wintered in Antarctica. He's just such a badass from a time when there were fewer people and men were made of stronger stuff. And
man, yes.
And his contemporaries were all these astronauts that went to space, and he was, walking down the same halls and serving in the same military as them and doing some of the same badass stuff. And he then went on to serve his country for over 30 years in civilian service, working in the DoD, and he got a doctorate in marriage and family therapy, and was counseling vets at the Navy Military Hospital in San Diego until just 5 years ago. So this is a man of service who's lived a distinguished life. And unfortunately, I think through a lack of forethought and counseling and maybe education on options, he's not living the most thought out, last few years of his life here.
Exactly. I mean, this obviously is someone who is full of life, full of accomplishments, and clearly had a zest for life in everything he approached. And I recall you telling me many occasions in the last year or so, that's gone, right? Like he's kind of checked down.
Yeah, I mean that's how I perceive it. I'm not making decisions for him, and I should be clear, he's not a patient of ours at this time. He's very proud to not cut in line. He's very proud to not be calling the VIP line. He's very proud to be using his doctors at the VA. He's not living his best days right now, and that zest for life is not there at this moment. And I think there needs to be a better conversation around what can we do to make him comfortable.
At this point, if he were my patient, I'd be saying, let's talk, palliative care, which palliative care is like one step below hospice. So palliative care basically says you have an uncurable disease. We're going to focus on treating the symptoms, making you comfortable. Hospice is when you say this patient likely has less than 6 months to live. We're really transitioning to the final stage of life, and we're going to really downplay treatment, as much as possible and focus on comfort. So in palliative care, for example, you may still be getting chemotherapy if you have cancer to keep the cancer at bay. Whereas in hospice, they're removing chemotherapy and it's just managing the nausea, the pain, that kind of thing. But that is how I want to go out. Like I do not want to, I've talked to my wife about this ad nauseum because I think about, because I've seen it and I've considered what the end may be like. I want it to be comfortable. I want it to be at home. I want there to be, Versed and morphine and ice cream and all the things that make the
hell yeah, man,
life,
yeah.
As you transition to the next realm as awesome.
My wife is also a broken record on this, and she shares your feelings on this 100%. She is constantly making me promise not to keep her plugged into a machine, not to extend her fight or her suffering too long. She wants to be living her best life until she can't. And then she wants to go peacefully and quickly. And I'm selfish about it. I want her around forever. So, and luckily we're 40 and we've got some time, hopefully.
You're not going to have that decision. It's going to be your kids.
Yeah, no, that's a good point. And that's got to become part of the playbook of health literacy is like, what are these stages of care? What's the game plan? And people need to be having these conversations in their 50s and 60s and not in their 80s and 90s when it's hard to participate in these conversations.
Exactly. And one other topic that I think never gets talked about, but I think should be talked about more is the idea of physician-assisted suicide. Like, there are cases where I think that's totally appropriate because, again, like, what people fail to consider is when they're doing everything they can to keep their loved one alive when they're not of sound mind and they're ill. Remember, although this person may not be able to verbalize their suffering, they absolutely feel it. And, I've said this before in a recording of mine, like, I think back to like when I would see patients like on the stroke ward who were really stroked out and couldn't talk. They can't move, they can't talk, they can't signal. But I can tell you they still feel. And here's the thing. A lot of them will be strapped in one position for hours on end. I want
super uncomfortable. Yeah. Excruciating from what I understand. Yeah.
Do a thought experiment. Just try to sit in place for an hour straight without moving.
No, man, I'm readjusting my seat the whole time. I'm like shifting. The podcast editors are like, stop moving around. Yeah. I can't imagine sitting still for hours.
Imagine an itch on your nose.
Mm-hmm.
And you can't verbalize, scratch my nose.
Well, that's why I'm keeping my wife alive so that she can scratch my nose.
Exactly. We'll make sure to keep her alive and, well into that. But in all seriousness, it's something that we don't get taught about in med school. I've never received any training on it. I honestly don't even know fully how it works.
Everything I've read about hospice care tells me that they are practicing a type of silent physician-assisted or nurse-assisted suicide. Everything I've read about hospice care tells me that these are people who have their own unspoken code and maybe spoken privately code of like, we're going to make these people comfortable and we're not going to extend their suffering.
Well, we even have it in the hospital. So we have a term called comfort measures. So what comfort measures mean is we're withdrawing care and we are basically going to give them a continuous increasing drip of morphine and a sedative. What we'll do is we'll look at their heart rate as a surrogate for, breathing rate as a surrogate for discomfort. So as the heart rate and breathing rate increases, we increase the drip of these two medications, the pain medication and the sedative, until eventually they stop breathing and they pass away. So essentially, we've been doing sort of a euthanasia style type, a euthanasia type procedure in the hospital for many years.
In a legal gray zone for forever. Yeah.
Exactly. But, I think what's different about a physician-assisted suicide is you get to pick like, hey, Tuesday is going to be the day I'm going to spend with my family. They have a packet of pills and I think it's a barbiturate and something else. But I'm not an expert. And the idea is that you can pass comfortably in your sleep. I don't know the ins and outs, how well it works, what kind of,
Dude, I'm hoping for magic mushrooms and opiates, but, barbiturates.
Mushrooms on your way out.
No.
I don't think so, man.
Okay.
That would not be the time.
Well, this is going to become a whole podcast series in and of itself. I think we've got a lot more exploration to do on this topic. I know we've got a few special guests we can bring on to talk more about this. And my grandfather's a hell of a tough guy. I don't anticipate that he's going to, largely because there's no plan for it. So he's not going to pass anytime soon. He's going to get his TAVR valve replacement in a few weeks, and he'll be a dutiful citizen watching Fox News once again very soon. I hope that what comes from this is some good planning, because I think he's suffered a lot in the last 6 to 7 weeks in this hospitalization, and I can't imagine that he wants to do that. 1 more time, 2 more times, 3 more times, 10 more times. So, to the article's point, I think stay out of the ER. Like, if you're a patient of ours, congratulations. Life is good. Call us anytime you need something, and we'll give you real, honest, careful counseling with informed consent about what your options are, and assist you in staying out of the ER if that's appropriate. But honestly, for those who aren't patients of ours, like, get to know your primary care doctor. And there's nurses lines that you can call at your primary care doctor. They don't always work. They're not always staffed. They can't always return your call on the weekends, but a lot of them are doing the best they can to relieve stress on this system. The ER sucks. If you're bleeding out, go to the ER. If you're imminently dying, go to the ER. But But do your best to know a doctor and avoid it when you can, because it is a miserable place.
Absolutely. I think that's a good take home.
Yeah. Well, Dr. Dave, it's a more somber ending than usual. We'll find some irreverent jokes to insert at the end here. But I appreciate you as always, man. I absolutely love your counsel, and I hope our friends, family, patients, and listeners got something out of this. Look forward to a lighter-hearted book club episode soon, and having a special guest on again soon.
Awesome. Yeah, it's always a blast and an honor, and I look forward to doing it again.
Thanks for tuning in to another episode of the After Hours Clinic podcast. Make sure to subscribe to the show on your favorite podcast platform so you never miss an episode. And if you love the show, leave us a review. You can sign up for our newsletter at joinbetterlife.com, and feel free to send in your hot takes and medical questions to podcast@joinbetterlife.com. Disclaimer: this podcast is for informational purposes only and does not constitute medical advice or establish a doctor-patient relationship. Content should not replace professional medical consultation. Always consult your healthcare provider for medical conditions. Do not disregard or delay seeking professional advice based on podcast content.